I'm going to go ahead and proceed with the basic examination for the foot and ankle. And what I'm going to do is I'm going to go through the minimum number of tests and measures in order to get the most amount of information. One of the things that I'm going to look at, as I've looked at in other joint systems, is whether or not there's any limitations, particularly limitations in passive range of motion. I'm looking for whether or not there is a capsular pattern or no capsular pattern. For the talocrural joint, that is a mild limitation of plantar flexion and a large limitation of dorsiflexion. So what I'll do is I'll go through the examination in supine, and then I'll demonstrate some additional tests that need to be performed for examination of the ankle. Okay, I'm going to start with dorsiflexion, and I'm going to do dorsiflexion in a couple of ways. The first thing that I'm going to do is I'm going to look at dorsiflexion with the knee straight. And so I can bring her all the way up to the in range of motion and assess the infield, and then I can bring her all the way up to in range of motion and let the knee bend just a little bit to unlock the knee, and then I can take her a little bit further. So there's my in range with the knee flex. So that's my full dorsiflexion. And I'm going to do the exact same thing on the opposite side. So I'm going to come in, bring her all the way up to the in range of motion of dorsiflexion, and then I can bring my hand up here to unlock the knee and take her to the full in range of motion of dorsiflexion. Next thing that I'm going to look at is plantar flexion. In this case, I'm going to let her foot fall, and I can bring her out to the in range of motion of plantar flexion and do a overpressure. Then I'll do the same thing on the right side. So bringing her all the way out to the in range of motion and overpressure. Already done the talocrural joint passive range of motion, and so now what I'm going to do is I'm going to do the passive range of motion for the subtalar joint. And for this test, I'm going to go ahead and slide the towel underneath her knee to keep the knee in a relaxed position. And so what I'm going to do is I'm going to look for provocation of the subtalar joint, with the capsular pattern of the subtalar joint being a pronounced limit in supination. And the primary component that I'm going to look at here is going to be the inversion component. So what I'm going to do with my left hand, I'm going to calcaneus, and my right hand is on the forefoot. And the forefoot is I'm just going to guide into that motion with my right hand, with the primary moving hand is the left hand on the calcaneus. And so I'm going to bring her into a supination or an inversion motion. So I can take up all of the slack and give a little overpressure at the in range of motion. And then I'm just going to switch my hands around. So now I'm going to look at eversion. So my right hand is now on the medial aspect of the calcaneus. My left hand is on the forefoot to kind of guide the motion. And what I'm going to do is I'm going to move the calcaneus in an eversion direction. So here is my eversion motion. So I can take up all of the slack and give a overpressure at the in range of motion. And I can repeat these on the opposite side, on the left side. So I can start off again with my inversion and supination. I'm going to switch the towel. My inversion and supination here. Now I'm switching my hands. My inverting hand is going to be my right hand. My left hand is on the forefoot just to guide it, and I can bring her into her in range of motion and give an overpressure, and then I'll switch to the eversion direction. So again, guiding with my right hand on the forefoot, and then my testing hand is the left hand at the calcaneus, and I can take her to the in range of motion of eversion. Again, this is a provocation test. And I'm going to show an additional test to look at the overall mobility and quantify that mobility in the prone position. I'm going to go ahead and demonstrate a mobility test for the subtalar joint. And what I've done is I've drawn out some important bony landmarks on the medial aspect of the foot and ankle that we're going to need to perform this test. Here where the red X is, this is the medial talar tubercle, and this is what I'm going to use to determine when the in range of motion comes for the subtalar joint. The other thing that I think I'm going to use is the sustentaculum tali, which is the plantar structure. If I palpate proximal from the plantar surface of the foot, I run into this little ledge here. This is where the talus articulates with the calcaneus. So this is the little ledge that the talus sits on right here. And so what I'm going to use is a line that I've drawn on her heel, which basically is a line connecting the sustentaculum tali to the sinus tarsi on the lateral aspect of the foot. The sinus tarsi is that little tunnel that sits in that space here where the fibular head and the talus come together. And so this is the little tunnel there. And so I can get a line that will give me the orientation of the subtalar joint. So this is the direction that I'm going to move the calcaneus in relative to the talus. And so what I'll do is I'll place my thumb here on the posterior portion of that medial talar tubercle, and what I'm going to do is I'm going to bring her all the way over into inversion and then all the way to eversion. And since my thumb is placed on the talus, the end of motion for the subtalar joint will occur when I feel motion under my thumb. And so if I start here at the end of eversion and move into inversion, I know I'm at the end range of motion about right here because the talus moves, that talar tubercle moves from underneath my thumb. So I can go from inversion to eversion and palpating the talus. So I know that I'm at the end range of motion for subtalar joint motion when the talus moves. The next part of the basic examination that I'm going to demonstrate are some diagonal tests that I'm going to do to try and isolate some of the soft tissue structures on the medial as well as the lateral aspect of the foot and ankle. And what I'm going to do is I'm going to divide it up into regions. And so I'm going to do the resisted diagonals for the lateral side of the foot, and then I'm going to do the passive diagonals for the lateral side of the foot. And then I'm going to switch around and demonstrate the medial resisted test and the medial passive test. And so basically what I typically do with my diagonals, if I have a patient who presents with symptoms on one side, and then I will choose to do the diagonals on that side. So if it's lateral sided pain after an inversion ankle sprain, I can go in and perform the diagonals for the lateral side of the foot, both passive as well as active. And so that's what I'm going to demonstrate now. First diagonal that I'm going to demonstrate is the diagonal for the extensor digitorum. And so for this one, I'm going to look at my resisted test first. So what I'm going to have her do is she's going to dorsiflex and evert, and she's going to pull up. And the cue that I'm going to give her is I'm going to use my right hand as my resistance hand. I'm going to bring my hand here on the dorsum of the foot, and I'm going to tell her to bring her foot up and out towards my elbow. And so again, I'm using my left hand as to stabilize the heel. I'm going to put her in a neutral position, about 10 degrees of plantar flexion. And so now go ahead and push up and out into my elbow. Push up, 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 and relax. And then I can proceed to do the passive component, which would be a passive plantar flexion combined with inversion. So I can take all the slack to the in range of motion and do an overpressure. The next diagonal that I'm going to do is going to be for the perineals or the fibularis muscles. And in this case, what I'm going to do is I'm going to have her push down and out. And again, I'm going to line my elbow up in a position to give her a cue. And so you're going to push down and out towards my elbow. Push against me, push, 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 and relax. And then I'm going to bring her up into a passive dorsiflexion with inversion to the in range of motion and overpressure. Medial diagonals, and the first one that I'm going to look at is the anterior tib. And so the resisted component is going to be dorsiflexion and inversion. So I'm going to line myself up in that diagonal, placing my hand on the dorsal and medial aspect of the foot, stabilizing the calcaneus with my left hand, and now I'm going to have you go ahead and push up and in towards my elbow. Push up, 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 and relax. And then the passive component will be plantar flexion and eversion. I take it to the in range of motion and do an overpressure. The final diagonal is going to be for the posterior tib, and for this one it's going to be plantar flexion and inversion. And so I'm going to change myself up. I'm going to get lined up in the diagonal again. I'm going to place my right hand on the medial and the plantar surface of the foot, And then her direction is going to be push down and in towards my elbow. Push down and in, push, push, push. Good. And then I can bring her up into dorsiflexion and eversion to test passive tension of the posterior tib and a overpressure in that position. Okay, I can assess whether or not my patient has pain or limit in dorsiflexion in a weight-bearing position by asking the patient to slowly squat while trying to maintain their butt over top of their heel. So go ahead and squat for me, and I can look for when the heel raises off of the ground and then coming back up. And what we'll see is if there's a limit in dorsiflexion, the involved side will come up, the heel will come off of the floor more rapidly than the uninvolved side. The other thing that I can do is I can perform a unipodal squat where I have the patient take the left foot and just barely toe touch on the left foot and put your weight on the right foot and repeat that squatting motion. And again, I'll look for whether or not the person has pain provocation and how soon that heel raises off of the floor. This is particularly useful for the patients who have anterior talotibial compression syndrome and pain in the anterior aspect of the ankle.